morning or good afternoon, depending on where you are in the country. On behalf of the National Reach Coalition and the Arizona Telemedicine Program at the Southwest Telehealth Resource Center and the Department of Health Promotion Sciences at the University of Arizona's Mel and Enid Zuckerman College of Public Health, I extend a warm welcome to all of you who have joined us today to be part of this conversation on the role of communities, that is, those most affected by racial disparities, in addressing those disparities, particularly in this era of COVID-19, and the role of health departments, federal agencies like the CDC, and academia. I'm Charmaine Ruddock from the National Reach Coalition, and I will be helping to facilitate this conversation. The timeliness of this conversation cannot be overstated, as we are squarely in a time of pandemics, a health pandemic, an economic pandemic, and a racial pandemic. And the racial pandemic includes the other two. We have a fascinating trio of panelists: Dr. Leandris LeBird, Dr. Danny Avula, and Daniel Dawes. In a few minutes, I will introduce them with a reading of a brief bio of theirs. But just to restate, the topic of our conversation today is flipping the paradigm, community leading health equity efforts, and what is the role of these particular agencies or organizations in addressing that. The COVID-19 data, as we are all aware, is particularly staggering for racial and ethnic minorities. Currently, for the COVID-19 death rates per 100,000 is as follows. For African Americans, is 87 per 100,000. American Indians, 56. Hispanic or Latinas, 53. Asian, 36. White, 36. Native Hawaiian or Pacific Islanders, 35. The disparate outcomes of COVID-19 pandemic have laid bare the racial and ethnic health disparities that have long plagued our communities of color. And the mission of the National Reach Coalition since its inception in 2004 has been to highlight the work being done in the communities addressing racial and ethnic disparities, while also ensuring that those communities are providing leadership in the national dialogue and call to action in eliminating health disparities and establishing health equities. Helping us to discuss these disparities and the leadership of communities addressing them, and the collaborative role, as I mentioned, of public health departments, academia, and the CDC, are Daniel Dawes, Director of the Satcher Health Leadership Institute, Executive Director of Health Policy, Associate Lead for Government Relations, and Professor of Health Law and Policy at Morehouse School of Medicine, and author of The Political Determinants of Health and 150 Years of Obamacare. He's currently the editor of the Johns Hopkins University Press Special Book Series, Health Equity in America. Daniel has long argued that health disparity must be a critical focus if we are to improve the health of all Americans. And in his book, Political Determinants of Health, he clarifies and spotlights that political determinants of health create the social drivers like unsafe neighborhoods and lack of healthy food, which affect all other dynamics of health. Our second panelist, Dr. Danny T.K. Avula, MD, is Director of the Richmond City and Henrico County Health Departments, and he's a pediatric hospitalist at Chippenham Hospital. Dr. Avula was appointed to the State Board of Social Services in 2013, served as board chair from 2017 to 2019, serves on several community boards, and has been named one of Richmond's top doctors every year from 2013 to 2019. He has been given many awards. His work has been featured nationally by the CDC, the New York Times, NPR, PBS's NewsHour, Christianity Today, and MSNBC. And whenever you get a chance, please check out Dr. Avula's TED Talk. Dr. Leandris Luberd is Chief Health Equity Officer, Associate Director for the Office of Minority Health and Health Equity at the Centers for Disease Control and Prevention. She has experience in chronic disease prevention, community health promotion, reducing health disparities, and community engagement. Dr. Luberd has been the recipient of several awards, including the Excellence in Collaboration Award from CDC, the Distinguished Service and Leadership Award from the National Reach Coalition, and Top Blacks in Healthcare in 2014 from the Johns Hopkins Center for Health Disparity Solutions and BlackDoctor.org. Dr. Luberd has been an outspoken supporter of communities in public health, and she has worked tirelessly to improve minority health and health equity for all people. Welcome to you all. We're going to ask our panelists to, starting with Dr. Luberd, to introduce themselves, talk a little bit about their work, the role in their organization. Dr. Luberd.
Good morning and good afternoon. As Charmaine said, and thank you to the Reach Coalition, the National Reach Coalition, for this invitation to be part of this important discussion today. As all was already described, I'm actually right now, I have two roles. I'm serving as the Chief Health Equity Officer for the CDC COVID-19 response. This is the first time in the agency's history that there has been a Chief Health Equity Officer for an emergency response has been part of the senior leadership of the response. And I'm also the Associate Director for Minority Health and Health Equity, and I've served in that capacity for since 2011. But I can also say that I've really spent my entire career in some facet of addressing racial and ethnic health disparities. But I want to say just to not take a lot of time, that the purpose of our Office of Minority Health and Health Equity is really to strengthen CDC's capacity to address health disparities, to improve women's health, and to ensure that we have a diverse and inclusive public health workforce. And so I look forward to saying more about our work at CDC as the webinar goes on. Thank you.
Charmaine, you're muted.
Thank you, Daniel. Daniel, please go ahead.
Okay, I'll go next. Well, thank you so much, Charmaine, for that very generous introduction. And I'm so honored and delighted to join everyone today, to join this distinguished panel and talk about these issues of health equity, right? This triple pandemic, as Charmaine was mentioning earlier. So just to give you some insights into Morehouse School of Medicine and Satcher Leadership Institute, we are a historically Black medical institution. We were founded in the mid-1970s to increase the diversity of the health professions and public health, and to advance this audacious goal of health equity nationally, right? Not only within the state of Georgia, but nationally. And so, recently I took over the Satcher Health Leadership Institute, which was founded by David Satcher, Dr. Satcher, who was our 16th US Surgeon General, which is a part of the Morehouse School of Medicine. And right now we are focused on, basically advancing or creating systemic change at the intersection of equity and policy. We want to be that leading transformational force for health equity, both domestically and globally. And so how do we achieve that? We've been focusing on three primary areas, three priorities. One is advancing mental health equity. The other is advancing equity through health system transformation. And then the third priority for us is the political determinants of health. How do we address the causes of the causes of the causes of health inequities, right? That have been concretized into our institutions and structures. So that's a little bit about who we are, where we're going, and what we hope to achieve. But again, very delighted to have this conversation with you today.
Thank you, Daniel. Dr. Avula?
Thanks, Charmaine. And let me first say what an honor it is to be on this panel with two actual giants in the national health equity conversation in Daniel and Landers. It's really a pleasure to be here. I am a local health officer. I'm a public health director here in the city of Richmond and the surrounding county of Henrico. I am a physician by training, a pediatrician, preventive medicine doc, and decided at some point during my clinical career journey that 15-minute office visit, particularly for my patients who are low income or people of color, that office visit was doing very little to impact their health outcomes. And I became interested and challenged by the layers of life, of complexity of putting food on the table and housing and culture and policy, and how all of those things were bearing down on low-income families to create circumstances that really did not allow them to have the opportunity to be healthy. And so that was my introduction to public health. I left clinical pediatric practice and decided to commit my life to the more systemic work of public health. And in a parallel journey, my wife and our family about 16 years ago moved into what was at the time an almost entirely low-income African-American community in downtown Richmond. And so over the last 16 years, this work of community development and understanding the impact of inequity and of racial healing has been a huge personal calling for us. And so not all of it by any stretch of the imagination has gone well. There've been a lot of challenges. I mean, we in essence, we're front end gentrifiers without knowing it. And so we have grappled in really personal ways with race dynamics and class dynamics and power dynamics. And that experience as a neighbor and a friend and a part of a community paired with the practitioner lens as a public health doc has really shaped the way that I think about these things, and hopefully the impact that we're able to have on the city.
Thank you, Dr. Avula. Thank you, three of you for kicking off our conversation. So for those who are attending, this is going to be in a conversational format. I'm going to pose questions to our panelists. Some I'll direct to one person in particular. Others, people will just respond as they see fit. So I wanted to start off our first question by asking, how do you see the role of communities in addressing racial and ethnic health disparities? Dr. LeBird, maybe.
Yes, I was trying to unmute. You know, I think it's impossible for us to really achieve health equity or to reduce largely preventable health disparities without intentional and robust community engagement. I think the absence of the involvement of the community undermines the impact of our work in public health. I learned this a long time ago. That's why I'm such an avid promoter of community engagement, even as I sit, you know, at the federal level. Many times I think we miss the conversations that are going on locally because we're making public health decisions absent those voices. And so we find that even in our surveys, low response rates. Why? Because we haven't taken the time to engage the community to help them understand the importance of the questions that we're asking, and or to ask them to help us frame those questions. I think that there are aspects of cultural and linguistic responsiveness that are missed and that are lost if we don't have community engagement. I also think that, you know, there is a power dynamic that goes into play unless we are intentional about bringing community members in as full partners. So I just want to start that discussion off with those observations and why I'm such a big proponent of community engagement.
Thank you for kicking it off really, really well. Um,
And Charmaine, I'd like to add that
sure.
to that notion that communities have power, right? Constitution starts with "we the people," and a lot of the changes that have been achieved over time to create and perpetuate and exacerbate health inequities, right, were created as a result of policy. So I take, through my lens as a lawyer and a legal scholar, I usually look at it through those lens and think about how it was communities that realized their power, who pushed for the creation of laws and policies that cemented these inequities in our societies, in our structures and institutions. 401 years ago, there were laws that were created by the early colonies, right? From Massachusetts to then Connecticut and New York, that prohibited slaves and indigenous populations from being able to grow their own gardens, to raise their own food, from learning to read or write, especially English, from prohibited from actually congregating in large numbers and basically socializing with one another. So we saw these laws being used to, and the power of those communities to create and then implement these laws. Today, and we've seen that over time from one generation to the next that have been recycled for the last 401 years, right? But today, I'm hoping folks recognize that these structural barriers, they're not permanent. And in order to effect the changes that we need to elevate this health equity agenda, it's going to take that collective action, right, from communities, knowing their power, knowing what they have, knowing that they can affect changes, and leveraging those levers, if you will, to push that agenda forward. So I just wanted to add that perspective onto what Dr. LaBerge was talking about, because I think that's a really great point.
Yeah, thank you so much, Daniel. Dr. Avula.
Yeah, thanks, Charmaine. So, one of the kind of fundamental roles of a local health department is to understand the health status of our community, to collect data, to parse it out by race or income class or whatever, and to figure out why is it that certain communities are facing health challenges and what can we do about it. And I think that, unless we are deeply and authentically listening to the people who have the lived experience that we're trying to sort out, we're going to miss it. And I just think of so many examples of where we look at health disparities and we, from the ivory tower of government or academia, try to determine exactly what is driving those. I'll give an example of flu vaccination, right? We've seen historically huge disparities in uptake of flu vaccine. And if we're not doing the work of listening to residents, we may assume that that's because of health access, or maybe it's an education. We need to teach people about the importance of flu vaccine. But then when you actually start to talk to residents, you understand that it's not an educational issue. It's not an access issue. It's that people just don't trust government and healthcare, right? We as institutions of government and healthcare have done atrocious things to Black people historically. And that has created a sense of skepticism and resistance to mass vaccination or mass healthcare provision opportunities. And so that doesn't come without really listening to people and what they're saying and how they're experiencing the things that we're doing. And so we have got to hear that voice and change our approach if we hope to be successful.
And Charmaine, if I could add on the heels of what Dr. Avula just said, because we actually talked about that this morning, this issue of distrust and sort of the frequent mention of the Tuskegee syphilis study, Henrietta Lacks, as we are in the month of her 100th birthday, and those eras of forced sterilization of women of color. And then people who are not sensitive to this or aware of this will think, well, that was a long time ago. Why does that keep coming up? Well, it's kind of bored into the consciousness of those communities that have been impacted, and it's passed on from generation to generation. And we are walking right into that with preparing, as we like to say, the community for the new COVID-19 vaccines. So there's going to be a huge amount of work in terms of not just helping people understand what goes into the development of these vaccines, but helping them to trust that that's what's in it has more benefit than harm. And so, I welcome all of my colleagues' wisdom on how they will be attempting to do that in the months to come.
Great. Thank you. Thank you, Leandris. So I wanted to ask, I love this conversation, started off really great. I wanted to follow up by asking, we just talked about the role of communities. And so my follow-up question is, how have your agencies or institutions worked with communities to address racial and ethnic health disparities? Dr. Vula, do you want to start off this one?
Sure, happy to do that. So, I've been here at the health department for 11 years now. And again, as I said, one of our foundational roles is to assess the health status of our community and to understand what drives health inequities. And so, pretty early on in my time, doing some geomapping of our data, really trying to figure out what communities are affected with different health outcomes, and then starting to be on the ground in public housing communities or other communities of concentrated poverty, and which is typically here in Richmond, concentrated minority poverty. And so, I'll give a real practical example. We had a grant about 10 years ago from the federal government to expand access to family planning. And so we started to look at where are we seeing the highest rates of teen pregnancy, where are we seeing the highest rates of sexually transmitted infections, and let's go there to try to set up access points. And so we came up with this idea and worked in partnership with the Housing Authority to develop mini clinics in our large public housing communities. We call them resource centers now. And we just kept running into roadblocks about what's the design model going to be and how are we going to get folks to show up. And it really wasn't until we, again, started listening, right? Started talking to residents saying, what do you need? If the health department is going to come and provide services, what could that look like? Or what would be helpful to you all? And we heard things like, we have a lot of elderly folks who just need a place to check their blood pressure or check their blood sugar. These are the things that people care about. And we at Chronic Disease was not really on the radar for us because we were funded by a family planning grant. We were going to do family planning. And so what happened after really months and years of deep community engagement, not only did we define a service model that ultimately served the community more effectively, but we also heard as we started to screen and listen for the broader social determinants of health, we recognized that employment was a huge barrier and that many of the residents of our public housing communities had expertise. They had a CNA or a lay health worker certification and wanted to help us and be a part of improving the health of their own community, but didn't have a avenue or a mechanism to do that. So we started raising grant money and hiring them as community health workers. And over time, we were able to solidify that funding. It took many years, and thankfully the philanthropic community was really generous, but ultimately the local city government said, this is such a meaningful intervention, we're gonna put money, a line item in your budget. And so about 3 years ago, we were able to establish full-time benefited community health workers, each of whom were hired out of the communities they serve in or grew up in that community and have since left. But what we saw over now a decade of this work is that the authenticity and credibility we have with the community is completely different because we've hired people from those communities as experts and we've followed their lead and their understanding of how we use institutional resources to try to support health. And so the community health workers have completely changed the way that we approach our work. They've completely changed the credibility and trust we have in our community. They've done amazing things even just for the role of community health workers across the state. One of our community health workers started the statewide CHW network and worked with state government to create a certification process for CHWs. We're now actively working with our state Medicaid program to create a sustainable revenue stream. So it has been a remarkable success to see how community health workers have changed our understanding of the communities that we're trying to serve.
Great. Thank you, Dr. Vula. Daniel, did you want to
Sure. Yes, I'd like to also add. Sure. So, in terms of how we look at it at the Satcher Health Leadership Institute and at Morehouse School of Medicine, we believe that the people who are closest to the pain, closest to the problems, right, should be the one leading the solutions. And I think, this is in line with what Dr. Avula was saying in terms of the community engagement piece. We recognize in this country, when Dr. Liburd mentioned the notion of Tuskegee, right? And what happened there with Henrietta Lacks. But even when you look at that issue that took place, that study that took place, there were Black physicians who were used as pawns in that effort, right? We recognize that even Black folks who were well-intentioned were doing harm. And we are very careful with our mission not to repeat history in that respect. We come at it with a very, very humble perspective, believing that the community should be the one, leading whatever solutions it is we think, or helping us to address the issues, right, that we want to partner with them on. And so when we present data, we present it, but we ask them to tell us, what do you see as the most pressing issues in your community? So just as an example of some of the things that we've been working on, in Southwest Georgia is the area of our state that has the lowest life expectancy and the poorest health outcomes, right? They're in the upper quartile when it comes to, the poorest health. And when we went into that community, we had not had footprints in that community before, but we went in because we recognized they'd been devastated by natural disasters. Hurricane Michael had devastated the region. I know Dr. Liburd knows what I'm talking about in that area. They, as a result of the hospital closures that were taking place in the rural areas of that state, in our state, we noticed that folks were lacking access. And so we decided we wanted to take the greatest challenge, because if we could move that needle of health equity forward just even a little bit, we knew that we could scale that up nationally. And so when we got there, we recognized there were folks who were living in motel rooms, right? They had to be bused, from out of their county into maybe 2 counties over to get to school. There were issues dealing with broadband access that they couldn't get because we were trying to figure out how we could provide telehealth services to these individuals, right? So it was quite a feat, I think, for many of us. But throughout the years, we've learned, there are certain elements that, Maslow has taught us that you've got to meet in terms of the security and so forth. And folks there were job insecurity when we got there. So we created a community health worker program, right? And have been working with our policymakers to get funding for these community health workers so that they can get remuneration. We've been working with communities that actually are culprits, or organizations and businesses that were culprits in creating many of these inequities to begin. When you talk about redlining communities, right? From the commercial banks to the grocery chain stores and others, bringing them to come and help us with the community to hear what was going on. And if you don't have thick skin, let me tell you, you might have walked very quickly, because there were some heart-wrenching stories that were told. The issues of racism that were alive, even in rural Georgia, right? That folks were plagued with, and even exacerbated because of the natural disasters, and now because of COVID. So there are elements to this that I think are really critical that we've learned, and it sounds like Dr. Avula and I know Dr. Liburd also recognize that have proven to work. I do believe that every community is unique, and a one-size-fits-all approach doesn't necessarily work. But there are elements of this that I think are scalable that we are taking to the next level.
Great. Thank you, Daniel. Sure. Then I'm hoping that you will, in response to this question, talk a little bit about REACH, knowing that you helmed REACH for a very long time. So in terms of the role of how CDC has worked with communities and the role CDC has seen that communities should have in addressing racial and ethnic health disparities.
Yeah, thank you, Charmaine. You are exactly right. I mean, I had the absolute privilege of being able to be a part of the REACH program for 7 years. And last year, we all celebrated the 20th anniversary of the REACH program. REACH was a real innovation at CDC, as we were able to create coalitions and also in some instances, direct fund community-based organizations, as well as state or local health departments, as well as academic institutions. And so we learned that when we tap into the genius of the local community, they know what to do and they can get it done in not a lot of time. And we also discovered, one thing I discovered I was particularly sensitive to is that those communities that were politically well organized and also savvy, who knew how things got done, who knew how to interact with the city council or the county commissioners, who had access, they were even more successful. They were able to do things that some other institutions weren't even able to do. And so we learned a lot from the REACH communities and continue to learn a lot. And I continue to be, I think, the REACH program's #1 fan. And every time I get a chance to just speak to how important the REACH model is, I absolutely do that. I did want to say, if I could talk a little bit about our health equity strategy for COVID-19 and kind of how I think communities should be engaged in that process. So, as a federal agency, we typically work through state, local, tribal, and territorial departments of public health. We encourage, promote, push for community participation and engagement. But from where we sit, we can't necessarily direct that unless it's a program like the REACH program or somewhere the community leadership is clearly written into that. But so we have 4 priority strategies for the COVID-19 health equity strategy. And the first one is around increasing the evidence base, which means that we're pushing for more data, for more complete data. We need to understand more the drivers of transmission in communities that have been put at high risk for COVID-19. And again, I think community participation in that process is going to be absolutely key. We have another priority, which is to increase access to testing, to help people understand contact tracing and why they're being asked so many personal questions. And we've run into some barriers with that. Also to increase isolation options for those who may not be able to do that in their own home, and to ensure that people have access to health care during this time when many people don't have health insurance. And then also to talk about, and I've mentioned this before, the vaccines, and as they will ultimately become available, we need community participation in the middle of that, just centered, central to that. And then our third, which also requires broad community engagement, is that we're really trying to do more to protect what we now call essential and frontline workers. And essential workers, in addition to healthcare workers, but essential workers who are the grocery store cashiers, essential workers who are custodians, who are construction workers, people who are working on farms and in meat packing and poultry packing plants, those essential workers. We absolutely need community participation in that. And then lastly, and this is to just build on what Daniel said, our fourth strategy is to ensure that there is a diverse and inclusive public health workforce that is engaged, who come equipped to be able to work in an increasingly diverse U.S. population. And so we need people who come from different backgrounds, who speak multiple languages, who can be trusted and can garner the community's trust, and who can work on their behalf.
Great. So
I'll stop right there.
Absolutely a wonderful lead-in to the next set of questions around the pandemic. So one of the things I wanted to ask the three of you to respond to is the fact that there's a lot of data that's readily available, not only at the national and state levels, but at the county levels, right? how can community organizations, including REACH grantees that are working to address COVID-19 disparities, use this data? And is there any specific type of data that they should be focusing on? You know, who wants to?
Yeah, Charmaine, I'd love to talk about that. I'm glad you got to that question. And I noticed that Barb Clint had actually raised a question in the chat box related to this piece. So, you know, I want to start out by saying that we know that COVID hasn't been striking all communities equally. And why is that? Because our social and economic policies haven't been benefiting all equally, right? When we look back in the history of this country, every single time there's been a pandemic or an epidemic that struck communities, you know, who do you think's been on the downside of advantage and opportunity every single time? It's been the Black community, indigenous groups, immigrant communities, and lower socioeconomic status communities, right? Always, consistently. And we know too that every single time we've had a challenge with getting the data in real time. We've not been able to access the data. We weren't able to get it disaggregated to understand the racial disparities at that time. And it wasn't until after that event, right? After that pandemic or epidemic had subsided, that we got to crunching the numbers, looking and analyzing it, the data, and we realized, oh my gosh, it's the same result again. So this time around, we decided in 2020, with all of the technological capabilities, as you mentioned, with the data, there is a lot of data that is helping us. Still, we can't get as granular as we'd like, but there is the data, and we'd like to be able to access. So we started a coalition called We Must Count. This coalition was spearheaded. We have 45 organizations that worked to get local and state policymakers, both public health leaders, as well as legislators and others, to help us get that data, to disaggregate it by race and ethnicity, so we could get a better snapshot of who again was impacted. We know that the data exists, and we want to see it. So we finally got some snapshot when you had South Carolina coming out, sharing that data with us, then Virginia, and I'm sure Dr. Avula had some power in making sure that happened, where we recognized that Richmond had 100% of the folks who were dying were African-American. It opened our eyes even more. Then the same thing with Milwaukee, Wisconsin, 100% of the people who died at that time were African-Americans. And then Michigan and Chicago, Illinois gave us that data, right? But they still weren't as transparent. We still weren't getting the data. So this time around, we said, we are going to create a system that will track health inequities in the United States. So right now at the Satcher Health Leadership Institute, in partnership with Google, the CDC Foundation, and some others, we are creating a comprehensive data platform to track health inequities, not only relative to COVID-19, right? Where we will look at the inequities in terms of getting access to tests and in terms of vaccinations once they're created. Because again, when we look at the studies with vaccine, we know who has been the one that has been the last to receive those life-saving vaccines, right? How will they be equitably distributed once they are created? So there'll be issues looking at remdesivir access. How long are folks staying in hospital beds based on their race or ethnicity? Do we see disparities in terms of the duration of stay, access to the ventilators, ICU beds? Do we see issues of unconscious biases, and where do we see them regionally in this country? We'll be tracking those. Then we want to also use this data platform to track health inequities related to those underlying health conditions. So we're going to track obesity related disparities, diabetes, heart disease, lung disease, asthma. We are looking at lupus, sickle cell anemia, as well as maternal mortality, et cetera. And then we're going to look at tobacco usage, right? We also then want to look at the behavioral health pieces. So as we get into this, as we continue in this triple pandemic, we know that loneliness, right, depression and anxiety are going to take its toll. And so we want to look at the disparities related to addiction, suicidality, anxiety, depression, and Alzheimer's. And then we want to take all that data that you've been saying with the around the social determinants of health and overlay that along with these historical maps that we have from these red line times all the way before and after to get a fuller, a richer picture of what's going on. And if that wasn't enough, we want to then look at the political determinants of health. We want to overlay that, looking at jurisdictional policies that have been exacerbating or mitigating racial and ethnic health inequities throughout the country. And so we've been basically tracking these. We have legal epidemiologists, a whole team of folks who have been working to collect this data and then to analyze and encode it for the system. So we're very excited about those opportunities. And I think it's going to be a game changer in helping us to understand in real time where these inequities lie, right? Where do we see an exacerbation of inequities relative to whatever disease group that we're looking at, or chronic disease that we're looking at, and then figure out from that what is needed, what solutions can we then come up with that will stem the tide of inequities in America. So we're very excited, and we welcome folks to join us in that work if they're interested.
Thank you, Daniel. I know a lot of people are very interested and excited about that work. Dr. Vula, from a public health department perspective, what are your thoughts in terms of how communities should be using the data that's out there?
Yeah, I mean, we try to lead conversations with data, and well, let me take a step back and say that one of the more powerful tools we've been able to use is data that's disaggregated by race, because it starts to tell a story that people may just not be aware of. And what Daniel just described, we've done a bootleg version of that here. I basically go back to the redlining maps from the 1940s in Richmond, and then fast forward 70, 80 years and look at health outcomes by census tracked across our city. And what you see is what Daniel was describing. It's those red line neighborhoods that have been historically disinvested in. And now those are the communities that have the highest rates of communicable disease, the lowest life expectancies, and so on and so forth. And so just kind of walking people through that progression helps them understand that this is not an accident, right? But this is a result of some really intentional policy and action over decades and centuries. And so that starts to change the conversation for communities. But in the same way that they recognize, oh man, it's the rules and the policies that created the situation, there is new hope and new life that can be birthed out of saying, oh, it's changes in policy that are going to get us out of this. And so what we have seen, and probably the one that I'm most excited about here in Richmond, is an amazing nonprofit called 6 Points Innovation Center that has rallied youth in their community in Northside Richmond to really grapple with housing policy and understanding how housing policy has led to the concentration of poverty and the lack of opportunity that so many of those residents face. And now high school kids are understanding the impact of that, the power of their voice in the policymaking process, and being connected to local policymakers. And so high school kids are regularly having conversations and informing the decisions that our city council makes. And now we have a generation of young leaders that have this in their blood and are going to change the city moving forward. And so I do think that the data is the beginning of storytelling, which ultimately, hopefully offers hope that leads to action.
Muted myself again. Thank you, Dr. Vula. Leandris, when CDC through the data identifies hotspots, how do they engage the communities in terms of informing them about that hotspots and determining sort of what needs to be done, helping them to use that data and that recognition to address it?
Yeah, so, from the standpoint of the COVID-19 response structure, we have a number of different task forces, and, several of them are devoted to data analyses. And there's one group called the Data on Call team. And so they, I think, have spent probably the most time in using analytic methods to determine hotspots. CDC, through the response, works again principally through state, local, tribal, and territorial departments of public health. And so what we do is to provide those data. Some of them are online. You can go to the CDC website for COVID-19. There's a lot of data online. But I think more locally, we work through the health departments. We also, have what's called craft teams that actually go out to local to work with local health departments, and they work with them around data and other issues, kind of how to respond to the data, providing recommendations, helping to do some collective problem solving with them. And so I think that's really principally how CDC connects the data that we provide with local communities. I did, if I could, Charmaine, someone asked a question about the data coming to CDC, and again, I guess hearing that it was no longer coming to CDC, and I think I know what they were talking about, but let me just say that the data that we get comes from laboratories, they come from healthcare providers, they go through state health departments, and then they're provided to CDC. I think the particular, and that has not changed. I think the particular instance that the person in the chat box raised is about, there was for a short period of time, about 6 weeks, where hospitalization data was not coming directly to CDC.
Right.
That decision was reversed, and now it is. So we're back to where we were before. And yes, you can have confidence in the data.
Charmaine, I might add a little bit to that question about the CDC, just because we've been real-time beneficiaries of the CDC's monitoring of data. So if I could take a couple minutes and just tell that story.
Absolutely.
In the midst of this COVID pandemic, the CDC is monitoring hotspots all over the country, and Richmond actually popped up because of the disproportionate impact of COVID in our Latinx community. At various points, we've had 40 to 50% of our cases in the city impacting the Hispanic Latino population, despite only 7.5% of our residents being in that category. And so the CDC reached out and said, hey, this is what we're seeing. What would it look like for us to support you? And so after about a week of conversation, the CDC sent its first all Hispanic team, COVID response team, here to Richmond. And so we had 6 phenomenal people, 2 public health docs, community engagement specialists, epidemiologists, and a behavioral psychologist. And they were not only delightful, wonderful people to work with, but they really came alongside, integrated with our local health department approach, gave us extra expertise and boots on the ground to do community level surveying and focus groups, and really unpack the drivers of disease in our Hispanic community. And we took a lot from that. I mean, not only did we have a better data picture and understanding of what was going on, but we also recognized that there were things about our approach. Even though we had Spanish speaking folks on our staff, we definitely didn't have enough. And the difference between being bilingual and bicultural made a huge difference in terms of the trust and the connection we were able to ultimately achieve with that community. So we changed our hiring approaches and efforts. We were able to recruit on about 20 new bicultural and bilingual staff since the CDC team was here. So just a quick anecdote of how the CDC partners with local health departments and ultimately local communities based on the data to actually impact health.
Great, thank you. Kudos, kudos to CDC. Thank you, Dr. Avula. Daniel, what percentage do you think of COVID-19 data is currently being gathered? 10%, 50%?
I have no idea. So I won't even come up with a percentage. I'll just say from my vantage point, it's not enough. Mm-hmm. And that is what has motivated us to get involved in this work, to start collecting, aggregating this data, pulling it from various sources. So we're not only going to be collecting public sources of data, and we're so grateful for the CDC's involvement in this. I know Dr. LeBird will be a part and has been a part of this effort with us, along with you, Charmaine. So we're grateful for your leadership. We will also, in addition to these public sources of data, be collecting private or incorporating private sources of data. Because what we want to do is to look at how the data differ, the public sources of data from the private sources of data. How do they align? How are they not aligning, right? Are there discrepancies? And so we will take data from provider groups, we'll look at GPOs and others that are collecting data within EHRs. I'd love to be able to see if there are true disparities in a certain region that perhaps the inpatient data isn't capturing it. So all of this outpatient data, I'd love to have access to it so we can see what's going on there as well, right? Especially when you're dealing with communities that have limited access to healthcare. So I'm sorry I can't answer it specifically, but I don't believe it's enough. And I believe we have to get more granular than we've been able to get in the past. And that's going to be our mission moving forward.
Okay. We're going to open it up to questions that we see coming up in the chat, but I wanted to just have you all comment. There is a significant concern that while the pandemic has laid bare to the country the existing racial and ethnic health disparities, that once we get beyond the pandemic, please God, that the momentum will be lost, and the communities that have historically been suffering from these racial and ethnic health disparities, that the veil will once again come between the rest of the country and those communities until the next pandemic or the next epidemic hit. And so my question to the three of you is, what's the recipe for making sure that the momentum continues and that communities help drive this effort?
So Charmaine, I think your fear is warranted in light of what we have seen in this country. Again, using my policy lens, when you look at the dearth of policies that have been achieved in this country to address health inequities, knowing the history of how short-lived many of them have been, right? So going back 150 years to the first ever comprehensive health equity legislation in 1865, which then was eliminated 7 years after that, and how long it's taken us to realize even piecemeal approaches to this problem. It's a very difficult feat. So I think your fear is warranted. I would say, in terms of what I think is that secret sauce or that recipe for success, it's about understanding that health equity begins and ends with the political determinants of health. It is about continuous engagement and not just voting, right? A lot of folks think, okay, I voted, I've done my piece, my civic engagement, and that's enough. No, when you talk about racism does not sleep in this country, and we can't afford to become complacent. And so it will take the effort, this collective effort from all community members, as much as they can get involved, to continue not only with voting, but throughout that process, right, of creating these policies, of informing these policies, of making sure that their lens is used when it comes to crafting these. And as you heard when Leandris was talking about how the successful communities that she's seen are the ones who have been able to work with their policymakers, right, at that level. That is so true. In order to prevent that pendulum from swinging and unraveling, that political pendulum from swinging and unraveling, the gains that you've made in your community, you have to make sure you are there at every point to keep them informed about why this is still a critical issue. Because we tend to get amnesia very quickly. We tend to forget what happened, just a few years, much less a generation ago. And we have to constantly remind policymakers and our larger society of these causes of inequities.
Thank you.
So the only thing I can add to what Daniel said is we're going to need the ongoing leadership from groups like the National Reach Coalition and from other national public health organizations. And I won't name all of them because I don't want to put all of them on the spot, but you know who you are. We need that commitment to continue to push this agenda at the national level, to garner commitment an ongoing commitment from policymakers and other decision makers. And we also have to ensure that we sustain, robust community engagement. And also, let's continue to highlight the effective community-based health equity programs and initiatives. And I think that, when people see that it matters, because I think there has been an awakening in the nation because of COVID-19, and this expression we used a lot about it having laid bare long-standing social inequities and health disparities. And so we don't want to move beyond this point without also carrying forward our commitment to undo those moving forward.
Thanks, Andres. Dr. Avula.
One of the things I heard both Daniel and Leandra say is this idea of continuous community engagement. So in addition to CQR, continuous quality improvement, we should be doing continuous community engagement. And I think for institutions like mine, a local health department, that means like changing up our DNA, right? It means like shifting our culture and going about our decision making and our allocation of resources and our design and strategy of our programs. Like all of that has to be driven by community voice. And so I think as we learn how to lift every voice, that we won't lose the momentum, because for Black and brown people, they live it and feel it every day. And so even when the rest of the country forgets about it, they will not. And so as long as we are in touch, hearing that voice and ensuring that that voice drives the things that we do, I hope that we can sustain some of that momentum.
Great, thank you. I'm going to go to a number of questions in the chat. So one of the first is, and it's to all the panelists, can you comment on multilingual resources or support and impact on refugee communities and how to capture their information or experience, highlight who's doing it right? Anybody wants to comment on that question?
I'll quickly say we do a lot of refugee resettlement in Richmond and Henrico here. We are fortunate to have both Commonwealth Catholic Charities and the IRC that do a phenomenal job, at least in their local chapters here in Richmond, of really supporting refugees past that initial placement. And even in the midst of COVID response, they've been incredibly helpful to us to tell us, hey, here are the language and culture groups that you all need to reach more effectively.
Right.
Here are translational resources we can offer. So I do think the answer to that question is going to be largely local in terms of what resources you have available and who's really serving refugee populations in your community. And thankfully here in the Richmond Metro, we've got some great ones.
And I'll just add, although I'm not in that area, I have colleagues who work in with refugee communities. And as many of you might have heard, we received a grant to work with HHS on linking communities of color. And this includes refugee communities. So we have a group of folks who are working with us, and I'd be happy to put you in touch. One of our scholars is Gigi Bastian at Morehouse School of Medicine, who's been working on these issues, and I think she would be able to answer that way better than I could.
Yeah, and I would just add, again, if I could direct you to the CDC website, there is a multilingual translation type service that CDC provides. And we have translated COVID-19 prevention messages into, more than 55 languages. So we have gotten a real sense of the diversity in our nation and the need for more language access, particularly right now during COVID-19. So I would encourage you to go to the website at CDC for COVID-19.
Okay. Another question in the chat. In lieu of Black Lives Matter, maybe in light of Black Lives Matter, what is each agency's response to systemic and institutional racism in terms of addressing it now and beyond the current crisis? And the elephant
so
in the room just
yeah,
said it.
this it's the elephant. Well, I can say that at CDC right now, we're having many conversations about racism and its role in public health. But I also have to say, having been at CDC now for more than 3 decades, to give my age away, this isn't the first time that this issue has been taken up. I'm going to say it's the third time in my tenure there. And there are a lot of things that have happened that have been sponsored by the agency, by different parts of the agency that people aren't necessarily aware of, because it wasn't this like broad agency level response or admonition. But you will see that changing. And CDC does absolutely see racism as a public health crisis, and is setting up structures within the agency to take, I think, on the science of that. But we'll see, I think time will tell how this focus will evolve.
Thanks, Andres.
For us at the local health department level, I'll just offer 2 practical examples of what's come out of this. One is a much more developed forum for hearing the experience of our own employees. I think in the light of George Floyd and Breonna Taylor and Ahmaud Arbery's deaths, we started to just create virtual and in-person spaces for particularly our Black employees to just say, hey, like, how's this feeling right now? Like, what are you going through? And so for our non-African American employees, I really think it was one of the first times that they had any sense of the weight that our Black colleagues carry every day in the midst of this crisis, but even outside of it. And so it has, fundamentally changed the understanding of a huge segment of our workforce here. And so we have committed to just creating that space on a monthly basis. And we have an internal director of health equity, and she hosts a lot of conversations internally about race, and we've been doing that for a few years. But I do feel like the weight of this time has drawn other people into the conversation who may not have otherwise. And then the second practical thing is that the specific issue of police violence and police brutality had never really been on our radar as a local health department. We do work in gun violence and injury violence, injury prevention, but I think the specific issue of police treatment of minority residents has now more clearly been framed for us. And so now I and one of my colleagues are working actively with our mayor and the police chief on the Marcus Alert system, a crisis behavioral health integration into our police response. We have 2 of the members on our health department who serve on the mayor's Reimagining Public Safety Task Force. And so we're starting to bridge into these areas that we may not have otherwise.
And,
thank you, Dr.
Even though I'm not an agency, Charmaine, I do want to add that from Morehouse's perspective, we have, long, of course, been spearheading these issues and trying to come up with the solutions. So from our very existence until today, fighting racism has been the core of who we are. But in terms of what we're doing now, we have been working, I would say, further upstream, right? Working to address those levers of power when you look at it from a governance perspective. And so we are working with board of directors. We are working with board of directors at hospitals, at health systems, among the payers, all of these stakeholders in healthcare and public health and beyond, to get them to recognize how even at that governance level, right, they have been, perpetrators, essentially, of keeping the status quo. And so we are working with them to address those institutional racism. We're working with our policymakers across the board, and we've been doing this for several years now, working with mayors, working with council members, as well as those at the state level with health commissioners and so forth. So they can recognize how their own agencies have been actually involved in these efforts that led to the result we see today, and how we can work collectively to address them and overturn what has resulted over those years. So we're working at that very top level in governance, working with these policymakers to get them to address it. And then working with providers. In fact, we're starting a new program with the American Medical Association for physicians. So with their power and privilege, they can take that and understand their role in helping us to overturn the state of affairs, right, as we see it today. So very exciting stuff. And again, like I said, I welcome the opportunity to work with those who are interested in those projects.
Thank you. We have maybe time for 2 more questions. One, are there resources, guidance for different states in terms of the types of policies we can implement to advance health equity? In Colorado, I haven't yet found a clear agenda of types of things that would improve this or that we can advocate for. Like best practices for policies for equity. Is there a place? And Daniel, I'm gonna ask you first because I knew you were involved with that, with a Helen, or still involved with that Helen initiative.
Can you repeat the question for me? I was actually about to respond to someone in the chat.
Sure. Are there resources, guidance for different states in terms of the types of policies we can implement to advance health equity?
Are there resources? So yes, thank you for that question. So as you mentioned, we formed the Health Equity Leadership and Exchange Network. This is a partnership between the National REACH Coalition, Morehouse School of Medicine, and the National Collaborative for Health Equity, which was led by Brian Smedley. And the idea here is that we wanted to bring together folks from around the country who care deeply about health equity and want to see some substantive changes happen, right? And want to really get at overturning the status quo. So the idea was we didn't know, who were the health equity leaders in Colorado or in Minnesota or in Nebraska or wherever, right? And it was very difficult for us to harness that power of collaboration that we needed, even when we were working on the Affordable Care Act, for instance, to leverage that, to push that health equity agenda in that health reform law. So we created Helen to get folks to share resources. So in there, we have a library of materials, of policies. We update this weekly with our Helen Monitor, so folks are aware of what's happening. We focus, of course, at that federal level. I'd love to be able to do it by state, but for now it's focused on the federal levers that can be pushed and pulled. And in addition to that, we have been organizing roundtables with folks to, again, share these information. So we'll go into communities, into regions, hosting these roundtables with policymakers there, as well as with the federal and community leaders to figure out, okay, what else can we do that we haven't been doing, right? What other policy issues or ideas do you all have for us that we can push forth? So Helen, I would welcome everyone to join our network. It is healthequitynetwork.org, and it is open to everyone. It is a nonpartisan network, but of folks from all levels, whether you are a public health official, a student, a community health worker, a physician, or a nurse, interested in elevating health equity in your communities. So it's a great networking vehicle for folks.
Thank you, Daniel. Dr. Avula, I see that you're not muted. Did you want to say something?
No, I think I just left myself off mute. Other resources, we have been pretty connected with Race Forward and Glenn Harris, if any of you know him. And there's a framework, Governments Advancing Racial Equity, the GARE network, that have been really helpful to us as a local agency and to our broader community of institutions and partners in Richmond. So those are a couple.
Thank you. I'm mindful of our time, and so I'm going to ask each of our panelists to say something in closing around the topic, flipping the paradigm, communities leading health equity from your respective, from your particular perspective. Andrews, did you want to start?
Sure. First of all, I just want to thank again the National REACH Coalition for this opportunity, for this session, for the conversation that we've been able to have. And I just want to kind of harken back to the question around how do we maintain the momentum, and just reiterate the need for national health organizations, national public health organizations, for community-based organizations, and for state, local, tribal, territorial departments of public health to just recognize in this moment that we need each other, including our academic partners and policymakers. I think this is a time to form the kinds of coalitions that will benefit our entire society. I would hope that as we move from this moment of COVID-19, that we not lose sight of how connected we are to each other and how health equity is good for the entire society and that no one should be left behind. So that's what I would say, for communities to take their seat at the table, to demand conversations with your local health department and other policymakers, to no longer be passive or complacent in accepting of these historical patterns of health disparities.
Thank you, Dr. LeBird. Dr. Lula?
Yeah. I think living through this COVID pandemic has really shown our communities that all of the differential experience that communities of color are facing aren't because of COVID, but they're because of all of the underlying circumstances and drivers that Daniel and Leandris have talked so effectively about. And so I hope that for our collective conversation, that we recognize that, whatever the next pandemic is, because there will be another thing that reveals health disparities, just like COVID did or is. And I hope that this is a shot in the arm to actually address the underlying issues. And simultaneously, I hope that communities are finding their voice in a new way. And again, with the lens here in Richmond, we would be nowhere near as successful as we have been with our mass testing events and our engagement of low-income communities of color if we hadn't had the years of relationship building and authentic listening with those communities. And so now, that's an affirmation that this has to be the way that we do our work moving forward. And many folks in our sister agencies are seeing the benefits of that as well. And so I hope that we institutionally can take this and say, this is how we do business now.
Thank you, Dr. Lula. Daniel?
Sure. Well, I just have to say ditto everything that Leandris and Danny just stated. I really have nothing else to say but to thank you, Charmaine, for this opportunity. I want to thank everyone for the privilege of their time and having this conversation. So thank you to the National Reach Coalition. I think if there's one theme that I heard from Leandris and Danny in their closing remarks is that we have to strengthen our networks and engagement moving forward. And I think that is so key. We've got to understand, what these instigators of health inequities are, understanding and addressing the social and political determinants of health, understanding when they're at play. And I'll just leave you with this thought from David Satcher, who, is my hero and a great mentor to me. But he says, we need leaders who care enough, who know enough, right? They've studied these issues. They've made themselves fully aware of the issues of inequities and those drivers. They have the courage to do enough, right? It's not enough to think, I don't know, it's so inconvenient, but have that courage, do something about it and persevere because, in this health equity movement, this is really not for the faint of heart. It's going to take folks who have all four of those elements. And so I want to thank everyone again for this opportunity, and I look forward to collaborating with many of you moving forward.
On behalf of the National Reach Coalition and our collaborators, I cannot tell the three of you thank you enough for a powerful, thought-provoking conversation that we will continue to have with you. Thank you, Dr. Leandris Robert. Thank you, Daniel Dawes, and thank you, Dr. Dania Vula, for sharing your expertise and your wisdom and for letting us know what you're doing on the ground to make health inequities not permanent. But I think as I'll just use Daniel's words when he said, communities have power. Structural barriers are not permanent. Thank you so much for sharing your time with us this afternoon. Thank you all, and thank you for those who attended and participated and were in the chat. For any questions we weren't able to answer, we'll definitely look at the chat and respond to them. Thank you all. Take care, be safe, stay well.